And Baja is
Hi everyone, welcome back to another Monday afternoon VMR with Alec and I. And today it's, as Robbie likes to say, an all internal affair with myself and Alec and Vale, who's going to be doing the case presentation today, and then inscribing and teaching points. We have Magnus and Bahai and Sarah, who's filling in for teaching points. So welcome everyone. Alec, any updates about things in life?
No, I'm just on week two of service this week. Things have been quite busy. We're admitting today, so yeah, looking forward to learning a lot and solving the case. Hopefully, Vale is kind to us. But yeah, I guess Vale, you want to introduce yourself again and tell us what's going on? No, no more babies. Trying to avoid that for now. But yeah,
Sure thing. Thank you guys for having me. My name is Vale. I'm joining you from Lima, Peru. I'm an IMG applying to neurology this year. And don't worry that you're going to do amazing with this case.
thanks, Vale. Yeah, and then maybe we can get Magnus and Bahay to tell us what's going on, and then Sarah to introduce herself as well, and then we can get the whiteboard up and get going.
Yeah, hello everyone. My name is Magnus, and I'm here to help out because Baja is scribing for the first time, but I'm sure he's going to do great.
Hi everyone, my name is Behat. I'm originally from Morocco and I am an intern here at CHE Rabat, and this is my first time scribing alongside Magnus.
And hey, I'm Sarah. I'm a medical student at Emory, and I'm applying into neurology this year, along with Vale. And I'll be doing teaching points until Gerardo gets here.
Okay, thank you so much, team members. So yeah, what if we get the whiteboard up and we can get started? Austin, who wants to take the first Alec?
Big brother first, I think.
Duh, all right.
Okay, so for today, I have actually two simultaneous cases for you guys. So I want you to kind of like imagine me on the words. And I mean, these patients didn't come up at the same time, but they came on the same shift with very similar shift complaints. So I'm going to give you the first aliquot of both patients. So the first patient is a 35-year-old woman that presents to the ED with a 1-day history of left-sided facial drooping. She first noticed she had some dribbling of fluids from the left corner of her mouth, and also some complaints of she could not fully close her eye. Besides the weakness on her face, she denies any limb weakness, any numbness on the face or on the body, any double vision, any problems with hearing, dizziness, or headache. And then for the first aliquot of the second patient, so this is a 68-year-old man that presents to the ED, mentioning sudden onset right-sided facial drooping and some problems with speech, some slurred speech. This was 3 hours ago. He was at work and suddenly noticed that he could not speak well. And he also reported that after this started, he felt a little dizzy, nauseated, and steady for some minutes, and then he came back to baseline. But he has the persistent facial weakness since 3 hours ago. So yeah, this is the first aliquot of these patients. What do you guys think?
Wow, amazing start, Vale. Thanks so much for preparing not only one but two cases. So awesome. So I think just to get my initial reflections, I think what was really striking me is how much the age can influence what's going on, and then also how isolated the symptoms are. And I'll sort of get a little bit more into that. So for the first patient, we have a young woman. We don't yet have the background, but even young people can have a rich past medical history. But if we assume not, I think what strikes me is that the patient has sort of hyperacute to acute facial droop, but there's really no other associated symptoms, right? There's no speech impediment. There doesn't seem to be any difficulty swallowing. The patient doesn't have dysarthria. There's no sort of headache or other neurologic vocality. And sort of as Vale noted as well, there's no numbness and tingling. And so the more and more I think about that, so what controls, the facial muscles? And that's cranial nerve 7. And it seems like the the fact that she can't close her eye makes me think that it's not just partial involvement, meaning that it's not central, it's more likely to be peripheral. And the fact that it's isolated makes me, prioritize the sort of peripheral cranial nerve 7 neuropathy as well, of which there are a lot of secondary causes, but also idiopathic ones. So, I think the sort of acuity still makes me doesn't want to miss a, an intracranial or a vascular event. But I think the sort of confirming the neurologic exam that signs are peripheral and the history sort of suggests that, I think will help us going forward. And sort of contrasted with the 68-year-old gentleman, also with an acute hyperacute syndrome, but it's facial droop plus, right? It's facial droop plus a little bit of dysarthria, some imbalance, some headache, some dizziness, which makes us run towards the CNS even further. And the exam can also be helpful to know, hey, is this cranial nerve, is this facial droop central or peripheral? And the way you can determine that is how much of the forehead is spared or not, because there's bilateral innervation of that. So I think also looking for other focality there. But I think with the age, that alone is increases your risk factors for a vascular event. And so learning the background of the patient will also layer in on top of that. And, in the end, these patients could share a similar diagnosis, but I think I'm sort of struck by how much less I was thinking about a vascular event when the patient was younger, and then how much more I was thinking about it when there were additional symptoms beyond sort of isolated facial droop. And I think those are sort of my initial reflections. I don't want to stop there and say, oh, it's Bell's palsy for the first one and a stroke for the second one, and we're done. Those aren't always endpoint diagnoses. You got to figure out what's causing them. So I think those are my initial reflections. And just an amazing way to present that. So Austin, I'd love to get your thoughts as well.
Yeah, I really couldn't add anything to that rich discussion. I think, as you mentioned, it's sort of understanding the time course a bit more. All we know about the first patient is that it's been a day of symptoms. We don't know if it happened like the snap of our finger or not. So that's something that we're going to have to gain some clarity into to make sure that we're solving the problem correctly. But it's sort of like, hey, I have a day of symptoms and I decided to show up to the ER now. So either that reflects that it was relatively mild to begin with and has slowly progressed and manifested itself. So they've noticed it, or the patient, oftentimes in these situations, it's like someone else that notices the patient's face first is the problem. And so that speaks to a little bit against the sort of hyperacuity of a syndrome, which would speak more to the idea that this is like peripheral in nature, as you mentioned. I think the other counter argument to that, though, is like a young person, like the threshold to go to the emergency room is generally quite high. So you can't really rely on that in and of itself. As far as the second person, I think, as you said, we were trying to understand the syndrome now as much as possible to see what company it keeps, to understand if like this is a relatively isolated problem that we're solving, or is there signal for it to be more systemic, as you mentioned. But the other thing that we validated sort of snuck in there was the idea of like not what happened, not just where things are now, but also where they were before. And so we learned that kind of preceding this, the patient was experiencing, along with some of their symptoms, or maybe even before, was experiencing dizziness, nausea, vertigo. And so the idea that this is, or I was translating it as vertigo, which can sometimes be dangerous, but nonetheless, I think that could speak to the idea of like going back to that sort of hyperacute schema that you brought up. Certainly vascular phenomena will cross our mind, but now I think in the neurological world, we have to think about an electrical phenomenon. And so in particular, like seizure, because seizure can do anything. And then the other would be, though, would be migraine, and then having sort of complications related to the migraine that are now manifesting. And that's what we're seeing. I think the other trap here is that the patient has slurred speech. And so we can translate that. Sometimes you can incorrectly translate that into something more than it actually is. Sometimes if your face is drooping, you can just sort of slur your words and it sound not so great. But sometimes it could be easy in your mind to inflate those with other problems. Like, is there a problem with aphasia, so I think that's something that we're going to have to clarify a bit more as well. But I think I agree with everything that you said, but I think just those other features sort of stuck with me as well. So yeah, excited to learn more, Vale.
Brilliant. Okay, great. So I'm gonna give you some of the southeast west, corner. So for the past medical history, the first patient, she was otherwise healthy. She only had the past medical history of asthma, but her last attack had been 5 years prior. She was in no medication. She had some family history of relevance. Her sister had MS that was recently diagnosed, but otherwise no other family history. Social history, completely unremarkable. No alcohol consumption, no smoking on her part, and she had no allergies. And for the second patient, his past medical history included hypertension and dyslipidemia. And he was on simvastatin, 20 milligrams at night, as well as amlodipine, 10 milligrams daily. And he was recently started on metformin because of pre-diabetes. So yeah, and otherwise he had not really past medical history, family history or any other part of this aliquot was kind of remarkable. So I guess my question for you guys is, how does this past medical history contribute to your differential diagnosis? And then what would you be looking for on the exam before I give it to you?
Oh, wonderful. Yes. So for the first patient, I think, Alec correctly predicted that the patient really doesn't have a rich past medical history. But we did learn that the patient has a family history of multiple sclerosis. I've looked this up like 17 times, but for whatever reason cannot commit it to memory. But sort of like the genetics of multiple sclerosis is interesting. There's not like one unique, if I remember correctly, there's not like one unique gene pathway to MS, though the family history of MS does confer some amount of risk to you that you could develop MS in the future. So understanding like if it's just, it is a first degree relative in a sister's and it was recently diagnosed. So that could potentially be relevant, but certainly it's not like simple autosomal dominant inheritance. So in and of itself, it doesn't necessarily mean that the patient's current symptoms that they're experiencing are MS. I think what can sometimes happen when you, and I encountered this today in my clinic, but if you have someone in your family or someone that's close to you that's experiencing health issues, that can sometimes influence how you interact with the healthcare system. So maybe the patient had been experiencing some of their symptoms for some time, but really it was so mild or so not bothersome that they never really thought to present, but something changed in their life, like a family member got diagnosed with a very unfortunate condition, and then that's sort of allows them to meet the catalyst that sort of allows them to meet the action potential to like go seek care as a physician. So I think sometimes understanding the background of that can be helpful. And then in people that have a clinical syndrome that's a little bit more challenging to characterize, then sometimes their background as far as the severity of their family or social situation can influence like how they present and interact with care. So that's something that I would just keep in the back of my mind, but wouldn't be particularly a top at this point. So as far as what I would want for my exam for this patient, I think a good neurologic exam by an excellent neurologist, which we have. So I'm going to rely on that, in particular with the focus on the cranial nerves, and then really looking for not just, I'm expecting to see a seventh nerve palsy, but really searching to see if there's anything else. And then as Alec alluded to before, like understanding the pattern. Is this seems to be purely like sort of motor neuron finding, or is there any sign that this could be deeper into the brain to suggest that we would need imaging? So would be what I would try to understand. So as far as the second patient go, I think once again, as Alec correctly predicted, this patient has a little bit more of a past medical history, just simply because they've lived longer and experienced life more. And so I think hypertension, hyperlipidemia, and prediabetes are, at least in the United States, are like incredibly common, age-related, and sort of diet and time related consequences of just sort of like living and breathing and working in the United States. So there wasn't anything too surprising there. However, these are risk factors for atherosclerotic disease, and so this would be something that you'd have to really push yourself a lot harder not to obtain imaging in this patient to look for a neurovascular etiology. But again, we're going to rely on our exam to try to make progress on where do we localize. So localization, we have some inclination as to the time course, but now we're really going to try to localize the lesion, and that's what the neurologic exam is for. Yeah, like I guess love your additional input, and then to try to challenge ourselves. I guess, and be realistic. Like, what if this person came to you got called to admit this patient, and then I'll challenge myself if this patient like came to my clinic, like what I'm going to be frank. I'm not going to do like every neuro test that there is. Like, I'm not going to test graphesthesia. Maybe I should, like, I don't know, but I'm not going to do it. So I'm going to try to challenge myself and say, hey, what do I actually need to do to make progress as quickly as possible initially? And so I'd love your input on that before and I'm going to I'm just going to try to give myself some time while you talk through it.
Okay, thanks there. So yeah, I mean, I think I don't know if the past medical history was really beyond what I was expecting. That's just the base rate of patients in general. Younger people tend to have less disease. Older people tend to have sort of more chronic conditions, and those chronic conditions plus the age tend to increase your risk of vascular events. So I think for the first patient, I think you could do a lot of things, but I think a good physical exam could maybe spare you things that the patient may or may not need. So I think, like Austin said, just being very purposeful with the physical exam and trying to assess, all right, is there a facial droop? Does it involve the forehead? Does it not? And then is it truly isolated to the seventh nerve, or is there other involvement? Is there an abducens palsy that's going on as well? Does the patient have some subtle dysarthria, right? Do they have ptosis? Do they have other abnormal extraocular movements? And then I think for most of my patients that have a primary neurologic complaint, just kind of like, patient has abdominal pain, right? It can be from lower thoracic pathology or sort of pelvic pathology. For the neurologic exam, I tend to go lower or higher as well. And that tends to just do you don't have to do like a full-on complete neuro exam, but I would do a sort of a cursory strength exam, a cursory sort of sensory exam, at least to light touch. And if things seem a little bit odd, or the patient's like, well, maybe I feel a little bit less, I might pull out my my tuning fork and my my safety pins. I have to go back to my office and get them. I never actually keep them with me, but just to assess that further. I think beyond that, if I really just picked up an isolated seventh palsy, I think then I don't know how much further I would get into it. Like, I don't know if I would get a CT scan or other things, just because of the base rate is if you do a good exam, it's probably peripheral. But I would be thoughtful of, if I do think this patient has an isolated cranial 7 palsy, what are secondary causes of that? I think of risk factors. So HIV being one that you would not want to miss. And then syphilis, and then you could think about if they had a recent viral infection. Oh, do they actually have a rash on their face? Do they have some vesicles? Do I need to take a deeper sexual history? Just thinking about those things. But I don't know if I would be immediately rushing to imaging unless I picked up some other things on exam. And you have to take in mind, sometimes like patients come to the ER with the symptom that's bothering them most. It doesn't mean they don't have other symptoms. It just means that the other symptom is bothering them enough that they don't put forth others, and you may have to pick that up on exam. So I think just doing a thorough exam, it's free, right? It's free for the patient. It takes your time, of course, right? But you can save people a lot of trouble. And then especially with sort of the propensity in the United States just to image people just because it's so convenient, you pick up things that you never knew about that lead to downstream effects. That may or may not be good. So I think, just a cursory good neuro exam, and you can go as deep as you want depending on if you find things. I think for the second patient, just by the sort of history alone, I would obviously do a thorough exam and do my best to localize the lesion. But I think even if I was like, oh, well, it could be peripheral, there's no way with the age and the risk factors and the time course and the temporality that I wouldn't be pursuing imaging in the patient. I'm just not confident enough in my neuro exam to not do that, especially with a patient with that many risk factors. So I think we could, I think Vale was already giving us her neurologic expertise by telling us how long the symptoms have been going on, and then we'll get to figure out how soon after the symptoms started the patient actually showed up to the ER, and that will influence management potentially. But I think for this patient, anytime I see like one neurologic symptom plus another, like you have to do a full neuro exam. And especially if it's acute and you're thinking about giving a thrombolytic, there's scores to guide you and things like that. Like the NHSS score and stuff like this. But I would be doing a more thorough exam, seeing how much the patient can participate, and then sort of trying to get definitely calling it code stroke if I felt the history was as linear as the ER had given it to me, if they hadn't done that already, just to get the right people on board and to get patient access to the scanner as soon as possible, because we know time is tissue, right? And we know that earlier intervention is better as far as improving neurologic outcomes. And it seems like this patient was fairly functional and wanting to maintain that, because dysphagia, dysarthria can change somebody's life very significantly. So yeah, I think Austin, I'm not sure if that's what you were getting at. I think the first one, I'm going to try to prove to myself that it's isolated cranial cerebral palsy, and then think about sort of other secondary causes, but may not be as super aggressive with the workup. But if I see anything plus, I will. And for the second patient, if I confirm that it's facial droop plus, then I'm going to go all in. And I think that's all in, and probably all in quick if we confirm it's more a hyperacute time course. But I think your idea of stroke and migraine of seizure and migraine are both very important things to think about, especially the way that in particular, like infarct can interact with seizure, through bleed or something else. So those are my thoughts. But yeah, I'd love to get your reflections before we pass it back to Vale.
No, you answered that superbly, far better than I could. And I think if I'm being totally transparent and today is October 27th, 2025, and maybe I'll look back on this day and say, wow, I was really dumb. But I would say for the first patient, I would do nothing but do a cranial nerve exam. Nothing. And if I proved to myself that it's lower, then I probably wouldn't do more of an exam, to be honest. And that could, for all the reasons you outlined, that would be a trap. But like at that moment in time, like unless there's something abnormal in the vitals or some sort of vibe I get during the visit, like I don't see the need to do anything more than that. So I think that, I think there's a lot of reflection I need to have on that, but like, I don't see why I would need to do anything if I prove myself that's lower motor neuron. Besides like, as you said, thinking about, is there any other features? But I would probably just do the cranial nerve exam by himself. For the second patient, I would definitely do a cranial nerve exam as well. I think I would probably, given the other symptoms, look in the ears and make sure that I'm not missing anything there. I do a cardiovascular exam just to assess that. And then if the patient is actively dizzy, I would do like the HINTS exam, which like you're going to get some of the components of that when you do a cranial nerve exam. But I would just clarify if the patient's experiencing dizziness at this moment in time, or if it's possibly triggered in nature, and that might clue me in to do like a Dix-Holopac or orthostatic vital sign, something like that. But then, as you said, like if there's anything that seems like it's not a lower motor neuron, like a pure lower motor neuron problem, then, and certainly if it's not isolated, then like you're going to do a full neurologic exam at that point. I totally agree. But I'm trying to sort of challenge myself to like be as efficient in my testing as possible. And I think it might come back to be like, wow, this is really dumb. I shouldn't have done that. But I'm just being transparent. Like that's probably what I've done in real life if I saw this patient. Teach me, Vale.
Oh no, I mean, I'm just smiling because I'm so happy to listen to you both discuss this case. I think I totally agree. I feel like, I mean, you have to imagine me on the ED, super stressed, thinking, why is the ED consulting neuro for a peripheral facial palsy, being a little grumpy about it. But then when you take the time to think about it, we have to rule out some quite important things that can present with a facial droop. Okay, so I'm going to give you guys the exam. So for the vitals on the first patient, completely stable, heart rate, it was 76, BP was 100/80. Yeah, otherwise was totally fine. On the general exam, the patient was in no acute distress. The other examinations, as Austin mentioned, weren't done by me. I focused on the neuro exam, honestly, right away. And the neuro exam right away showed a left facial drooping involving both the upper and lower face. So, and this was confirmed with when asking the patient to do some movements, so like smiling, closing her eyes really tight, or opening her eyes really, or like raising her eyebrows. So both the forehead and the mouth were compromised. She could not raise her left eyebrow or close her eye tightly, as I mentioned. Sensation was intact on the face as well as in all the limbs. There was no weakness that I could assess on my exam on the extremities. Other cranial nerves were completely normal. This is okay. So I'm gonna nerd out for a little bit right now. Thinking about like talking to you about my 7 nerve exam. So I love to do, you know, forehead, smile. That's wonderful. A little pearl there is that if you actually tell a patient like a joke or something, you even if they have some real droopiness, they can smile because that's another part of the brain controls emotional fibers. So if the patient is really giggly, they will have a normal smile, even if their 7 nerve is really compromised. So, but sometimes, you know, patients can have eyebrows that, you know, maybe they have Botox or they just, it's hard sometimes to assess the forehead. So I love to complement my exam with other things that 7 nerve does. So for example, the corneal reflex. I didn't do that on this patient in particular because it can be a little troublesome. So the 5 kind of receives the sensation on the cornea, and then the 7 does the closing of the eye on the reflex. And then I also did some taste testing. So we know that the anterior tongue kind of perceives the taste, the 7 does, and I always carry some sugar with me. And this patient did have some like, oh, it doesn't taste as it usually does. It doesn't taste sweet. It tastes a little like bland. On the left side as well. And for the second patient, we have some altered vitals. So he had some 160/90 on blood pressure. But otherwise, the other vitals were normal. On general exam, the patient was stable, you know, chilling on the ED, but he did have right facial weakness affecting his smile and also the rising and closing of the eye. He didn't have any dysarthria or aphasia. He could name things perfectly. On the eyes, we did notice he had some horizontal nystagmus with some, the fast face was to the right. But otherwise, the rest of the neuro exam was completely normal. He also had some impairment of the taste in his tongue. So yeah, what do you guys think about this exam and what would you want for the next aliquot?
Wow, expert neurologist Valley carrying around sugar to give the patients. I love that. And then, yeah, I had never heard of the telling a joke. I'd love to hear what joke you use from time to time, or if you mix it up. But so I can learn some Spanish jokes as well. But yeah, I think the first one, Valley with her expertise has really just confirmed that this seems to be peripheral. I don't see any other sort of red flags here that there's anything beyond that. So, you know, I think from there, I would just be thinking about what are the other sort of secondary causes of that, but most commonly it's just idiopathic. But, you know, I have personally seen cases of HIV that presented with, you know, Bell's palsy that were missed. And so some of that is some recency bias perhaps, but just to think about that, just patient has risk factors or not, do they have good follow-up? Say, hey, you know what, you know, they're happy, they're stable, they're walking, talking, eating, as Robbie likes to say, right? So I think, you know, I would, you know, try to see if they have good follow-up, you know, and you could think about whether or not you want to give the patient steroids, you know, plus minus, in antiviral, and sort of take things from there. Unless there were other red flags, and just, you know, give them clear return precautions and sort of send them on their merry way. Unless, you know, there's going to be a twist coming up, I'm not really sure I would do much beyond that. I'm not even sure I would get labs, to be honest, besides the ones that like could potentially cause it, because I'm not expecting any sort of odd electrolyte derangements or whatnot. So, yeah, for the first patient, I don't know if I have a lot of additional reflections. For the second patient, I think we just confirm, you know, he's hypertensive. It's unclear how well his, you know, hypertension is controlled at baseline. So I'd love to know, is this, you know, worse than his baseline? Is it something that's acute? I would say most people that end up in the hospital, their blood pressure is just higher than it is at home, just for a multitude of reasons. But keeping that in mind as well. And it seems not only that his, you know, face is weak on that right side. He's also having some a little bit of difficulty closing his eye, but he doesn't have any clear dysarthria or aphasia. I didn't hear from Vale about sort of peripheral strength or sensory changes, but he does have a little bit of nystagmus, horizontal nystagmus, and I would love to know if the other hint exam was done, and then if the nystagmus was bidirectional or not. So whether or not there could be a sign that there's a posterior brain, posterior fossa involvement there. But I think it's no longer facial nerve plus, it's something else, right? So like the cranial nerve 7 doesn't have anything to do with the extraocular movements, unless I'm misremembering things. So I think for me, like this does not pass go. Like you don't collect 200. I don't know if the kids get that joke anymore, but I think for here, the patient has concerning findings for a central etiology, and I'm not a neurologist, so I'll be honest and say I am sort of less inclined to be like, well, is the facial droop's on the right side, so it's probably on the left, but the nystagmus is going towards the right. What does that mean? And I'm less like, oh, is this in the brainstem? Is this in the cortex? I don't know, right? To me, I know this doesn't smell right? It hasn't passed the go test, and I need to image the patient's brain. So I think for here, that's what I'm primarily thinking about. The blood pressure is high, but if they're having a stroke, you just let it be high. You don't worry about it. The patient is chilling. Right now, like it's not like danger territory for a hemorrhage, right? So I think usually you think about that being 200 plus. So what I'm really moving forward with is, Valean in her expertise has picked up that this is more than just a facial droop, and it seems like it's doesn't involve completely the forehead, it spares it, and so I'm running towards the brain and trying to figure it out. And then I'm really just going to be thinking about the time course and management at this point. And I'm just going to be authentic to like I'm not going to be trying to like predict the CT scan with full clarity. But once I get the patient stabilized and where they need to, I'll be thinking about that, because the academic exercise is important, especially if you live in resource poor settings. Yeah, I think those are my reflections, Austin. I don't know if I can be more eloquent beyond that, but I'd love to hear what you're thinking.
Just before you say your thoughts, Justin, just to clarify, the second patient did have problems closing his eye as well. So both of them had kind of a peripheral pattern.
Okay, no, that's good to know. Yeah, I would think regardless of the eye, if he does have a peripheral pattern, still the nystagmus is interesting. And I guess if there is horizontal nystagmus as well, plus the dizziness, that does evoke the idea of a potential vestibular pathology, like Austin had mentioned before. So yeah, I think I would still be asking you, like, is the nystagmus bidirectional or not, or is it unidirectional? Because I think that would be helpful to me, at least, to think if there's a peripheral component or not, and then the rest of the HINTS exam. And then, I'd love to know as well if the patient had any dysmetria, or, if there are any other sensory or motor defects. And then, once I can characterize that a little bit more and better differentiate if it's central or not, or central or peripheral, then I can sort of figure out what to do next. So I thank you for clarifying that, Vale. Austin, what do you think?
Yeah, no, perfect. Yeah, I think for the first patient, at least for me, yeah, I would have just stopped at the cranial nerve exam, say, hey, this seems consistent with that. Like where I live now, like it's endemic for Lyme, so I'd do like the testing for that. Other than that, you might just say, hey, like, here's some steroids or acyclovir if you are a believer in that sort of thing, and then let's give it some time and see what happens. And I think, as Robbie has taught us before, like really the red flags of a isolated facial droop is like, hey, is it anything other than acute in onset? Like if it's hyper acute, like the first patient, this was acute, but the second patient, we already have a red flag, because a facial droop should not happen like the snap of your finger. That tells you that this is not sort of Bell's palsy. And that's what I mean, or idiopathic, so to speak. Like that suggests that there's another reason why this patient's experiencing it. The second is it needs to be isolated, which, as you've talked about, extensively, the second patient like is not isolated. So yet another red flag that we're experiencing here. And the last is like, hey, usually when you get the facial droop, unfortunately, it happens like relatively quickly and takes longer to get better, but most people don't recur. it's kind of like shingles in that way. The vast majority of people with shingles like do not get another episode of shingles, though it can happen rarely. But if you break any of those rules, then you need to, as you said, Alec, do not pass go, do not collect 200, like move to understand things a bit more. So, the first patient, like I don't think we need to invest too much into that right now. I can so totally imagine like with the patient's sister being diagnosed with like MS recently that, she could understandably like request or like want to understand why people aren't pursuing imaging of her brain. And I've come across this scenario, quite a few times. And you just have to have shared decision making with the patient and usually close follow-up, say, hey, like, I really don't think there's anything going on with the brain, but here's what we're going to do. I'm going to bring you back to my clinic in a few months. If things are not completely better by then we can reassess about how things are going and decide what to do from there. But if we're trying to be cost conscious and practice, cost conscious care, then I think, and high value care, I think that would not be a thing to do at this moment in time. But I can understand why the patient would be concerned that we wouldn't do that necessarily. For the second patient, yeah, I mean, I think now we're struggling to figure out, okay, if we know that there's some seventh nerve pathology, and we know that it seems to have a peripheral pattern, so to speak. But what do we make of the other symptoms that the patient is experiencing, which seems to be that we seem to have some nystagmus, as you mentioned. And so horizontal nystagmus, as you mentioned, most of the time that implies like there's a peripheral cause, but you can get horizontal nystagmus that is central in nature, just as you can get a peripheral pattern of facial nerve palsy from a central cause. Like that is a thing. But I think, Alec, as you mentioned, let's go back to the time course. Like if we're very confident that the patient was fully normal and at their baseline 3 hours before the onset of all these symptoms, then as you mentioned, like you're going to have to pursue the vascular hypothesis pretty heavily. And I think it would be, and this is where I'd have to lean on my neurology and radiology colleagues really heavily, because I don't think just sort of like your standard image sequences on CT or MRI are going to catch the type of things that you're looking for in this scenario. And then the earlier you are in the course of a vascular hypothesis, the least likely you are to find the lesion, especially if it's relatively small, because you just need time for those things to develop. And this is why the HINTS exam performs better than MRI in the first, I think, day or so after symptom onset, because your clinical exam is more sensitive than what we can do with the MRIs. Now, we've, at least in certain areas of the world, like we have now like 3 Tesla MRIs. And so this is why the concept of a TIA, there's this great JAMA paper from like a few years ago where it was a couple of neurologists that said like the TIA is dead, like it doesn't exist anymore because our tests are getting so good at detecting it. And so, depending on what type of quality MRI you had, like you might be able to make progress on that. But you have to say, hey, even if I get MRI imaging right now, it doesn't mean that the patient didn't have a vascular phenomenon. And this is where understanding the time course is really, really crucial. So if we, let's say we exonerate the vascular hypothesis, then really we're left with the electrical one, as you mentioned. And you'd still going to pursue imaging of the brain because like you want to understand what this patient's predisposition to like a seizure would be, for example. And then new onset migraines, so to speak, like in a 65-year-old, if they really have no history to suggest that, would also be like a red flag. And so we're going to pursue imaging in that way. So like there's really no way out of imaging this patient, but it's just trying to understand like what type of imaging are you going to get and what in particular structures are you going to be focused on? Do I just need a big picture view of the brain, or do I really need to focus on like the brain stem if we're focusing on like, hey, there's multiple cranial nerves that could be at play to explain the syndrome? And I guess if I remember my neuroanatomy like roughly, then you'd be thinking about like the pons area, like in particular, because it's like 1 through 4, and then it's like 3, 4, and 6 that would be involved in the extraocular movements. But then some of the pathways that would connect the extraocular movements could potentially like lead to nystagmus. But I think you'd have to at least think about making sure you get decent imaging of the brainstem, which a lot of times like you have to ask for specific sequences, et cetera, in order to get that, or a particular focus on that area of the brain. And then what else would I do? Yeah, I think I would, as you said, try to understand the nystagmus as much as I could, and then try to, um, yeah, that's really the only thing that I'm still like wanting to sort of get more clarity on. And then I would just be leaning heavily on my neurology colleagues to understand like, hey, where can I help localize this? But I agree that like I'm not 100% confident like I'm in the periphery. And if we are, there's enough red flags happening here that I need to just go beyond like what the base rate would be. So yeah. All right. Vale, excited to learn from you.
Wow, this is amazing. I honestly like, I feel like I was with you guys on the ED because for the first patient, I was kind of, a little upset because I was like, you know, I guess the ED should be able to deal with the peripheral facial pulse, blah, blah, blah. I was, you know, then later that same day, the second patient came on, and I was like, well, he also has a peripheral nerve palsy, and he doesn't have anything else. Like at that time, he didn't have dizziness, and the nystagmus was there, but it was horizontal, unilateral. I love that you put a lot of emphasis on using the HINTS exam, because at that time I didn't know that you could use the HINTS exam when you didn't have vertigo. Like even if you have nystagmus only, you can use it, and it's really really good. And as Austin mentioned, it's even better than an MRI. At the time I didn't know that, so I didn't do a HINTS, which that's my bad. But it's like a great teaching point. Like you can do a HINTS even if you only have nystagmus. Um, and so I was saying, and so for the first patient, yeah, we didn't do much, honestly, as you guys said. I love Alec's point of going for HIV. We don't have Lyme here in Lima, but HIV, I think, would have been wise. And that's something that I'm gonna put on my checklist moving forward because, it's really important. But the patient was discharged on steroids. Some acyclovir was also prescribed, and also some drops for her eye. And then for the second patient, I was talking with my attending, being like, well, if he had a stroke, I would expect him to have something else, right? The brainstem is so crowded, and especially the seventh nerve, it's very, very close when it goes out of the pons with the sixth nerve, but he didn't have any gaze pulses. So I was like, this kind of seems impossible, right? To have a stroke that does not compromise the sixth, but only the seventh. So I'm gonna show you the MRI that we got, just because my attending was like, no, he has a lot of risk factor, exactly like you guys. Just like, just in case. Okay, I'm gonna, oh, wait. Okay, can you guys see? This is a representative one, not the one of my patient, but quite similar. So we have a DWI and sorry, we have a T2 on the left side, T2 flare. And then I'm not really sure what this one is. I think it's probably T1 post-con on the right. But yeah, what do you guys think?
Yeah, I think I don't know anything about MRIs, but nonetheless, we have an arrow sign which is helping us direct us to the side of pathology. And I think, based off the cut we're at, you can see that we are at sort of at the level of the eyes. And then, so it means that we were pretty high up, into the brainstem area. And so this would be, based off where we were trying to localize things before, could put us into like the pons area. And then I think there's this like syndrome. It's like I don't know if it would apply in this scenario, like a lateral like medullary syndrome, where people can get like ataxia and like facial nerve issues. But I think I have to say my neuroanatomy and in neurology knowledge is pretty weak. So the first thing I would do is say, hey, we found something. Does it explain the symptoms that the patient is experiencing? And based off the little I know, I think that it seems like, hey, we made a rough localization, and it seems like it's kind of roughly in that area. So like, I'm going to suggest, yeah, maybe it could. But I'd really like have to look in real time and then lean on my subspecialist colleagues to understand that, because as Alec alluded to before, we do a lot of scans, and just in case, it's like where everyone that's sick in the hospital gets on telemetry, even though it's like not a useful thing to do and not high value care, but it makes us feel better. So like in this scenario, like we got the MRI to make us feel better, and like we found something, but is it actually relevant to what's happening to the patient or not? That's like an open question that we have to answer. I think the answer is yes, but yeah, like what are your thoughts?
Yeah, excellent. Thanks so much for the arrow sign. Really appreciate it. So I think, as Austin said, very importantly so, is that when you get an MRI and you see something, you have to ask yourself always, is the lesion in an area that explains the patient's syndrome? Because you will pick up, it would not be uncommon, right, for this patient to have had prior lacunar infarcts, because of the risk factors and the hypertension, prediabetes, and hyperlipidemia. And you found one, you'd be like, oh, well, yeah, lacunar infarct, right? Should be. But then, like, the lesion's in the basal ganglia, right? It doesn't make any sense. So I would say this patient has a lesion in the pons on the right side, on the same side that he has a facial droop, right? And it seems like he has some nystagmus, which the cranial nerve 7 palsy peripherally alone would not explain, right? Unless he had something in his ear, like he had like a schwannoma or something. But the time course really shouldn't be hyperacute, I guess, unless it ruptured or bled or something, right? And so this infarct here with a T2 on the, I think the left side's a T2, which I think. Oh no, it's the CSF's not bright, so it's a T1. I don't know. Anyways, so it looks like there's an infarct in that area. And I would say I don't know. I guess I would have imagined that the lesion there like wouldn't have like would spare the forehead since it's more central. But I don't know well enough if like the infarct's in the exact right place, like that's a little bit more peripheral, perhaps it could be overcome, but or you know, it could overcome the like sort of crossing fibers and could cause basal palsy. So I'm not exactly certain, but I would say yeah, I feel pretty good that this lesion probably explains the lesion's symptoms, right? And I think I would be working with our my neurologist and radiologist, you know, in real time to try and figure out, is there a hemorrhage component of this, or like is this just appear like an ischemic infarct, or you know, are we concerned that there could be embolic signs of embolic phenomenon here as well? Because certainly patients have risk factors for something else. So yeah, I mean, I think here I feel like we have a good sense of that this whatever is going on in the brain here, like he explains the patient's findings on exam, and then just you know, being sure I'm not missing any sort of consequences of this, either bleed or sort of hemorrhage, and then figuring out in real time if there's any evidence of like arterial occlusion, like more proximally, like I guess causing the infarct, that I could do something about in real time. Although I think with the location of the stroke and Pontine, I usually don't think there's like a large fascial occlusion phenomenon always, and if to be truly isolated to that, it would be less typical. But I think in most, if you're worried about a stroke, typically you would include the CTA just to be sure you would be able to do something about it beyond controlling the patient's risk factors in real time. So yeah, Austin, I think I agree with you. I think the most important point I want to make of that is like just because you find something on the MRI doesn't necessarily mean it explains the patient's syndrome. You have to be really thoughtful about like the patient has this, the infarct is here. Could this explain what's going on? And I think in this instance, I feel like it does. And I guess yeah, I'd love to learn from you about what you're thinking.
Yeah, no, that was a brilliant read. Yeah, sorry that I didn't give you guys the DWI and ADC. That was my mistake because honestly, that would be the best imaging on this patient given the time course. I mean, we wouldn't be able to see anything on T2 as I showed you guys right now, if this was like a 3-hour stroke. So yeah, it doesn't make sense. But on my patient, I don't have their imagings. But on his MRI, he did have a tiny lacunar on the right pons, on the lateral right pons, the restricted diffusion and had ADC correlation. And this was read as a fascicular seventh, or like a catching the fascicular seventh nerve, which is just like the portion that is going out of the nuclei before it leaves the pons itself. So yeah, this patient then was worked up for causes of stroke, was found to have AFib, was started on anticoagulation eventually. And yeah, I mean, this was a very, very humbling case for me because, as I said, I was like super biased from the first case, thinking, oh, it's another case of peripheral nerve palsy, like, but then as you guys signals from like the first aliquot, there were so many red flags that I think is super important, especially if you're like a general practitioner, you're on the ED a lot, like to be able to see, oh, what patient should I get neurology and what patient maybe I can just, you know, discharge and with some minor management, you know? And so, yeah, that was kind of the main thing for me, kind of seeing what are the red flags on what could be a potential like Bell's palsy before calling it a Bell's palsy, and who should I go imaging and who not. So yeah, thank you guys for this discussion. It was brilliant.
But I really loved this case. I thought it was like extremely real life about things that you would see and what you would do, because you could have done an MRI, a CT of the head, $50,000 worth of hypercoagulable labs for patient number one, right? When all they needed was a good neurologist like you, it's a Medrol dose back, right? So I think it's just because we can do a lot of things doesn't always mean that it's the right thing to do, and sometimes time is the best diagnostic test. And so I think Austin's idea, just good follow-up, shared decision-making, reassurance, having the patient come back to the clinic in a week or two, to be sure that the facial droop is getting better, I think is the right thing. And then, yeah, I think, but I have personally missed strokes when it was like this patient has like isolated like thigh weakness that's only present when he stands up. Everything, the entire nerve exam was normal, but had vascular risk factors. And a colleague of mine decided they were going to do an MRI because the time course was hyperacute and had the tiniest little infarct, I think in the thalamus, I think. It's just extremely humbling that patients, like your patients don't read a textbook, right? And so I think if anything I'm reflecting on, I'm just sort of like sad at myself that I can't localize things very well, but also sad that I know when things aren't don't sound right, and know when I need to sort of get imaging. And I think if anything, as an early trainee, that's what you have to pick up on, is just when things aren't as isolated as you think. And then the older the patient gets and the more risk factors they have, it's less, you can be less confident in your exam, just because of, and then you have to think about the consequences of not figuring out if somebody has a stroke or not. So I just love this like real life. I love that you were kind to Austin and I, and also led to I think a really real life discussion about things that you could do and the importance of that. And so yeah, I really enjoyed that. Austin, what are your thoughts?
Yeah, no, tremendous case and work, and thank you so much, Vale. I think if I'm being totally transparent, it's like the first patient, you didn't even need to do any the second patient, you didn't even need to do any neurologic exam you could order an MRI. You could walk in the room, see the patient has a facial droop, and ask them, hey, when did this start? Oh, this started all of a sudden 3 hours ago. That's it. Right? Now you could say, hey, wow, well, I have zero understanding of the syndrome. Like, what am I going to take a picture of? And you're 100% correct about that, to clarify. But even without even doing anything, you just look at the patient and then ask them one question, when did this start? You already decided to get a picture, right? So I love the idea of localization, but if you're trying to be as efficient as possible, it doesn't matter. You're going to image this person's brain, and yes, you should do that. Please, I don't want anyone to take away that you shouldn't do an appropriate exam for this patient. You 100% should. But if you're trying to be as efficient as possible, you figured out within less than 10 seconds that this person needed an MRI of their brain, right? The first patient, it's yeah, hey, now you need to do everything you can to convince yourself that this person doesn't need imaging. And that's the whole idea about it, right? Is that you say, hey, what am I okay missing? What am I not okay missing? And sometimes we inflate that to be hey, I don't want to miss anything, therefore I will order every single test. But that doesn't mean that you provided good care to the patient. It just means that you were not very thoughtful about what you were doing. And again, it all goes back to taking a good history, understanding the time course, and localizing the disease. And that's exactly what Vale did in both cases. And fortunately for the patients, they I think had the best outcomes that they possibly could. So really fascinating reflection. And I think one of the things that I've been trying to sort of focus on in my practice is what tests do I do as my physical exam, and when I ask questions that actually help me make progress, as opposed to just talking to the person and giving you a tiny piece of information, but it not actually being terribly clinically useful. I like to talk to my patients because I build a relationship with them, and so we talk about their kids and their family, and that's totally great. But if I'm really in the focus is to solve a problem, then we should try to do that as efficiently as possible, and that should be by asking questions in the most effective manner. And every question is a diagnostic test, and it should have a performance characteristic. And the same goes for a physical exam. And I don't think it gets, I never learned it that way in my medical training, but I ask about, sometimes I catch myself asking the patient questions. I'm why did I ask that? Like, it was like completely worthless. Like, oh, did the Tylenol help with this? It's like, what does that do? Like, it doesn't do anything. Like, so that's a little bit of me just sort of like how I'm sort of having like my own sort of like midlife crisis in my career about like how much I need to improve as far as like how I see patients. So I appreciate everyone on YouTube for putting up with it or just commenting about how they didn't like it later on and after the recording gets uploaded. But yes, tremendous. Thank you everyone for their work and everyone that joined. And then we will pass things along to Sarah to give us the teaching points.
Yeah, thank you both for your discussion and Vale for bringing this case. For teaching points, patient 1, the features of both face and eye involvement made the localization to the whole cranial nerve 7 more likely. We also talked about the base rate of vascular illness being lower in younger patients and higher in older patients. Patient 2 also had additional features that localized to the central nervous system. So on their background of being an older patient with more metabolic risk factors and their hyperacute timeline, the likelihood of a vascular event or seizure could have been higher. Inheritance of autoimmune conditions tends to be complex, so a first-degree relative with an autoimmune condition is not necessarily a certain sign that the presenting symptom is related to autoimmunity. Though a family member with an autoimmune condition may change the way that a person interacts with the healthcare system or influence how you as a provider are going to speak to them, being sensitive to the way that they're going to respond to you. In patient 2, the background of having metabolic syndrome increased our threshold to get imaging to rule out vascular events, even though their localization seemed to be peripheral nerve on initial exam. And for case 1, trying to differentiate between CNS and PNS localization was high yield in the diagnosis. Paying attention to sensory symptoms to differentiate between an isolated cranial nerve 7 lesion versus central nervous system or additional cranial nerve lesions is important. An important don't miss diagnosis in patient 1 was HIV, because that can be a presenting syndrome with Bell's palsy. Smile can be normal in cranial nerve 7 palsies if you elicit a true laugh from the patient. And additional tests that we sometimes don't get are corneal reflexes and taste, because cranial nerve 7 localizes to both of those tests. In patient 1, their exam localized to a lower motor neuron pattern of weakness, affecting both the upper face and the lower face, and she was low risk, so it would have been safe to, after ruling out don't miss diagnoses, send her home with return precautions. And then the direction of nystagmus can be helpful for precise localization of a central nervous system lesion. The HINTS exam should be performed in patient 2 because it has high sensitivity for central causes of nystagmus and vertigo. And additionally, it's more accurate than MRI very, very early on in vascular lesions. It can also be performed if the person has nystagmus and no vertigo. In patient 2, they might have needed a dedicated brainstem image, but luckily they didn't. And then finally, lesions that present less than 4 hours may not be visible on T2, but should be visualized with DWI and ADC correlation.
Thanks so much, Sarah. Really appreciate it. And Vale, before you go, I'd love to know what jokes you keep in your pocket when you when you speak to patients.
Oh, I actually have a bag like any with neurologists, I guess. The kind of funniest thing that I have is before I used to carry coffee for smell. I've never tested a smell on a patient, honestly. I haven't seen a Parkinsonian patient. I'm really looking for it. But now I got at the AN last year, I got a card that has like a lot of smells. So like you just scratch a little bit of it and it has like a variety of smells that you can test. So yeah, that's the one that I feel like it's just waiting for me in my bag to see if I can test it on a patient soon. But yeah, a lot of cute things that I could talk all day about my neurology bag. It's my baby.
Well, Vale, patients are so lucky to have you. I can't wait, for them to keep experiencing all your sort of your joy, your passion, and sort of benefit from your expertise. So thanks so much. Loved it. And thanks to Sarah, Magnus, and Mehe for doing all the teaching points and scribing. And I hope everybody has a great rest of the day. Thanks, Austin. You did all right.